This lecture here is meant to all candidates who are sitting for the exam of MS, DS, or MD in AIM-SHAMS or elsewhere, and it's on Introduction to Ophthalmic Anatomy course. Here you have my email where you can communicate with me any questions, any problems regarding the subject of anatomy. And this is where the subject is presented to you in photos. And I sent yesterday as well the link to my YouTube channel. Now, the education, as I said here, is for the degree of master's, the degree of diploma, and the degree of doctor. And the presentation here is meant to guide you through the course. As you probably heard from me before, education means three, or aims at three pivots. The first is knowledge, second is skills, third is innovation. And by knowledge, we mean to know. By skills, we mean to do. And by innovation, we mean to elaborate or improve or invent. Albert Einstein, the well-known, very smart human mentality all over history, has once said, been quoted to say, education is what remains after one has forgotten what one has learned in school. That's probably one thing that we tend to miss all the time. I mean, if you'd like to know if you have learned something during your school courses or not, try to recall it. And recalling after all these years, and finding yourself remembering well what was said to you or what you read is actually a successful education. It's not the learning of facts, but actually the training of your mind to think and elaborate. And being such a smart person, as we know, he was quoted to say that the only thing that interferes with his learning is his education. His education was much inferior to his capabilities. And I'm reminding you that teaching and learning are not the same. Teaching is what I'm doing now, and learning is what you are trying to do now. I may teach you day and night, but you don't learn. And otherwise, you may learn even without somebody teaching you, which is self-learning. The intersection of learning and teaching is the acme of a successful education process. The teaching strategy in the Department of Ophthalmology and AIM-SHAMS and in the Faculty of AIM-SHAMS in general depends on three axes. The first is interactive learning, the second is self-learning, and the third is continuous appraisal. In anatomy, we consider it one of the three major basic sciences being taught, being guided through in ophthalmology, besides physiology and optics. And we start by embryology. We talk about osteology. We give some instruction on surface anatomy, radiological anatomy, and then we go through flesh anatomy. And in embryology, you are supposed to know from your undergraduate courses that embryology begins at, the development of the globe starts at the 3rd week of intrauterine life. And the whole ophthalmic system is derived from the three embryological layers, which are the neuroepithelium, the surface ectoderm, and the extracellular mesenchyme. The neuroepithelium is known to give mainly the retina, which is part of the brain, as well as the ciliary body, the iris, and the optic nerves. And the surface ectoderm gives the crystalline lens, the corneal epithelium, and the skin of the eyelid, while the mesenchyme or the neural crest and mesoderm give out the sclera, the corneal endothelium and stroma, blood vessels, muscles, and finally the definitive vitreous. This is a video here showing how the small morula develops into a complete embryo. And what interests us in ophthalmology is that the formation of the face is through the formation of the frontonasal process in the middle and the two maxillary processes, and the optic vesicle develops at the sides, and the globe is first uncovered, then the lids become fused together and then re-separate for formation of the whole face. And this is another video showing how the heart starts as early as 6 weeks of gestational life, where there is a beating heart so early, while the embryo is still looking like a worm, and then all the developments go on hand in hand with the development of the head and neck and the eyes. The eyes are first exposed, then the lids form, then they are completely fused together, and then they re-separate. Now we come to osteology, and as from the undergraduate teaching and learning, you know that the bone is the main culprit of learning anatomy. And this is a video showing you the skull, and the skull actually is formed of so many bones. The vault and the maxilla and the mandible is the only mobile bone in the skull. The bones of the skull unite together through immobile joints called the sutures, and they are the foramina that give in and out inlets and outlets for structures from the skull to the rest of the body. For teaching purposes, this is the occipital, parietal, temporal, frontal, nasal, zygomatic, maxilla, and mandible. These are the bones seen on the outside of the skull. The two orbits, the nasal cavity, and we'll come back to that when teaching and when lecturing on the orbit. Here's a front view of the skull showing the two orbits and the other structures, the foramina within the orbit that give in and out. I'm sorry, I stopped because I'm trying to work out the pointer, but it's not working. I don't know why. Probably it's something in the settings. I'll see to that later on. The orbit has got, the skull has got two orbits, and we'll come to that later on. This is a side view where you can see the temporal fossa and the orbit, where the lateral wall is recessed backwards and the medial wall is more forwards. And for this, there are reasons, as we can see, and this is going to be explained in details in the next lecture on orbit. If you take out the vault and see the cranial cavity from inside, you will find it divided into three parts: the anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. The anterior cranial fossa is one, actually two sides united together at the midline. The two cranial middle cranial fossae are separated from one another by the site of the pituitary gland, the sella turcica, and the posterior cranial fossa is one. The posterior cranial fossa has got the foramen magnum, which is the very big foramen that gives out or lets in the spinal cord, and the medulla oblongata as part of the brainstem. And as you can see, there are structures coming in and getting out through the foramen lacerum, foramen ovale, and foramen spinosum. On the surface, that is, without cutting through the body, you can see the structures that you can feel on a living patient, or if you are intending to do surgery. And starting on the medial side of the orbit, you can feel the trochlea. That is the site where the superior oblique tendon changes direction, and the eyebrow is crossing the orbital margin, where the medial 1/3 and the lateral 2/3 unite at the orbital margin. The lateral part is above the orbital margin and the medial part is below. At the lateral part of the orbital margin, you can feel the supraorbital margin
دكتور شريف استأذنك الصوت مش واضح.
أنا آسف جدا، كده واضح؟ اتفضل. تاني.
تمام يا فندم، تمام واضح.
Supraorbital margin, if we follow it by palpation from medial to lateral, medially there is the trochlea, which is the site for change of direction of the superior oblique muscle, and the eyebrow crosses the supraorbital margin between the junction of the medial 1/3 and lateral 1/3 of the margin. And then laterally, you can notice the notch that gives off the supraorbital nerve. And then when you come to the lateral orbital margin, there is the junction or the suture between the zygomatic process of the frontal bone and the frontal process of the zygomatic bone. This is the frontozygomatic suture, which is palpable and also evident on a plain X-ray, as we can see later in the section of radiological anatomy. And then you follow the lateral orbital margin through the zygomatic bone, inferior margin, where 1 centimeter below, you can feel the infraorbital foramen giving off the infraorbital neurovascular bundle. And following it again up to the medial orbital margin, you'll find it continuous with the anterior lacrimal crest, which is very prominent. And then you cannot follow anything because here there is the cord-like structure, which is the medial canthal tendon, and then the superior orbital margin actually is continuous with the posterior lacrimal crest and cannot be palpated in this area. So this is the eye from outside. The formation of the structures of the orbit: first, muscles, vessels, arteries, nerves, fat filling everywhere, the globe itself, the extracorneal fat, and then the skin. The radiological feature of the skull and the area around the eye is going to be shown here. As you can see, this is an anteroposterior or a posterior view of the skull where the two orbits are seen. This is an illustration of the structures on the X-ray film. As you can see, number one is the crista galli, which is the bone bridge between the two halves of the nasal cavities. And then number two, this line here is the lesser wing of the zygomatic, lesser wing of the sphenoid bone. And number three is the zygomatico-frontal suture, which I've explained on the bone specimen a few moments ago. Number four is the imaging shadow of the superior orbital fissure. And then number five is the nasal septum. And as you can see here, the number six is not an actual structure, but it is a radiological shadowing of the inner wall of the temporal fossa, seen from the lateral view of the skull. And then comes number seven, which is the superior margin of the petrous ridge inside the cranial cavity. And finally, number eight is the maxillary antrum. Here they are, all. And on a CT scanning, this is a transverse view where you can see the orbital wall. The medial one, both medial orbital walls are parallel to one another, and the two lateral walls are converging to form a virtual angle of 90 degrees. This is again the transverse CT scanning, where all measures of the orbit can be taken. A coronal view can show you the inferior wall, show you the orbit and the relations to the two maxillary antra and the nasal cavity with its three conchae. Here, a CT scanning can show you the extraocular muscle and at certain cut levels. Again, views, these are the views of the coronal section of the two orbits. A sagittal section can sometimes in an MRI show you the structure of the extraocular muscles, where you can delineate the optic nerve and the levator palpebrae superior rectus complex. You cannot separate these two muscles or delineate them. And as you can see, the globe here is looking up, trying to make the superior rectus contract and try to make some separation between it and the levator palpebrae superioris. And while looking down, you can delineate the inferior rectus from the inferior oblique. 3D or three-dimensional CT reproduction is useful in elaboration and pointing out to some lesions and some masses in the orbit. We can add to the technology the cinematography or the scene views, where you can dynamically delineate the structures and some of the nerves. For example, here is the frontal nerve crossing from lateral to medial. And you can show out some structures in the anterior cranial fossa and in the middle and posterior cranial fossa in different sections. Again, another imaging technique is the B-scan ultrasonography. This first red shadow is the transducer of the machine, and this is the globe, and this is the optic nerve giving the W-shaped shadow. If you inject radioactive material, you can delineate the vasculature inside the orbit in a cinematographic fashion. Now we come to the flesh, where the cranial cavity is going to be gone through the adnexi and the globe. You know that the adnexi are the structures that serve in the adnexi are the structures that are connected to the globe and serve to secure its function. Here's the cranial cavity where the vault was taken off, and the superior orbital wall or the roof was taken off, showing the globe and muscles and structures around, and all this is going to be gone through during the orbit lecture. This is a cast of the blood vessels. The blue is the veins and the red are the arteries. And inside the cranial cavity, we can see the venous sinuses, the transverse, the sigmoid, the cavernous, the superior and inferior petrosal, and the straight sinuses. Let's see that again. These are the venous drainage of the cranial cavity channels. The adnexa are four: the extraocular muscles, the lacrimal system, the conjunctiva, and the eyelids, and all are going to be gone through in the course. And as you can see, here is a dissection of the orbit seen from above. This is a dissection of the temporal fossa where the zygomatic bony arch has been removed. And this is a dissection of the orbit where the globe has been removed. This is a lateral view of the orbit. All this is going to be taught in detail, but I'm now giving you a view of what is going to go on during your course. Here you can see the lacrimal gland, where part of it is in front of the elevator aponeurosis and part is behind, and you can see the lacrimal nerve and the ciliary ganglion with the red probe, with the green probe below it. This is a lateral view of the orbit with the lateral view of the skull cavity showing the sella turcica and the anterior and posterior clinoid processes. Now the globe anatomy is taught in two directions: the macroscopic anatomy or the gross anatomy, and the microscopic anatomy or histology. This is to remind you that the eye is the world. We see, we live, we enjoy through our eyes, which is the great gift from Allah subhanahu wa ta'ala. The globe in a section is three coats or three layers: the outer coat, the cornea and sclera, the middle, which is the iris, ciliary body, and choroid, and the middle and the inner is the retina. Filled inside posteriorly by the vitreous cavity, and anteriorly there is the anterior chamber filled by the aqueous, which circulates throughout. This is a video to show you the globe section, the cornea, where light comes in through the pupil crystalline lens to focus on the retina at the macula. You should make yourself very familiar with these figures to understand all the details that you are going to go through later on. I'll give you a hint on the applied anatomy, which means that we should know that we are not studying or learning anatomy for the purpose of anatomy, but for the purpose of serving later on in practice in clinical medicine and surgery. For example, if you give periocular anesthesia, the lower wall of the orbit, which is the floor, is not a flat line, but it first dips inferiorly and then comes up. If you don't know this, you're probably going to pierce the globe. See here, if you go straight, you may injure the globe, but if you go down and then up, you will give your injection in the retrobulbar area, safe away from the globe. So this practice comes from the good understanding of anatomy. Here is a surgical dissection of the eyelid during surgery for ptosis that I did to repair through elevator resection. Skin incised, orbicularis, orbital septum shown, orbital septum opened, where fat, pre-aponeurotic fat pad comes out, and then the levator aponeurosis is identified, dissected, and cut, as well as the molars fibers. And this is another example of applied anatomy where we are doing dilatation and syringing of the lacrimal system. And I am here showing you the probe going first directly vertical for 2 millimeters and then horizontally coming from the understanding of the anatomy of the lacrimal passages, where the canaliculi go first vertical, then horizontal. And here's the probe going again vertically, then horizontally, then passed through the nasolacrimal duct, which takes the direction of down, out, and forward towards the second molar tooth. And in this way, by knowing the anatomy, I can dilate, for example, in a child, inject saline, test, and diagnose the condition. This is another example of surgery based on the knowledge of anatomy, where we open for the DCR surgery. As you can see, this is the nose. This is a patient where the feet are up, the head is down, and the incision is made between the nose and the globe above the medial canthal tendon. This is the medial canthal tendon. And here, after opening the medial canthal tendon, where an instrument is passed through the nose and the nasal mucosa is seen after opening the bone. And this is a probe passed through the lacrimal sac, tenting its wall, where the surgery can be done through anastomosing both the mucosal membranes of the two sac and the nasal mucosa. And this is a last video showing you the endoscopic anatomy of the nose. This is the nasal septum, and this is the sac from inside, where you can identify, open through, and do surgery transnasal. Thank you very much. We finished the guidelines through anatomy, and I am conjoining in this lecture another part, which is how to present your work, meaning here to aid you, help you while preparing your thesis, which is supposed to be carried out after you finish your exams for the first part. And now sit and relax and learn how to present your work, how to make a presentation of a master's degree, or I mean a thesis. For those with a diploma degree, they are not supposed to prepare for this, but a doctor is all the time asked for speaking out, presenting in lectures, in teaching younger doctors. So this is going to be very helpful to you. I am tried throughout my lecture not to let you sleep. Of course, teaching online, I don't have a reciprocal relation with you. I don't have a feedback. I don't know who is sleeping, who is following me. But as you can see, it's so easy to let you sleep, to let you have a nap. How? By giving you a slide with too much text. You must have noticed that I minimized the text in all the lectures, in all the slides. I don't read from the screen. I'm speaking and having just small messages on the slide. I gave you lots of images, videos, and collaterals. And I started by giving you the structure of my lecture. I said I'm going to talk about so and so, and then we shall talk about design mistakes. So for you to have a good presentation, you should use little text, and this has got a rule that we are going to talk about later on. You should not be reading from the screen. You should use a lot of images. You should give the structure of your talk or your presentation in the form of a small story, and you should avoid design mistakes. What are the classic design mistakes that most of us actually do? First of all, excessive bullets. This here is called the bullet, this dot at the beginning of the sentence. You should avoid excessive bullets. You should avoid excessive fly-ins, which we call animation, and you should avoid annoying sound effects. Now the rule of 6. Remember this, the rule of 6. You should use no more than 6 lines per slide, no more than 6 words per line. You should design a chance of only 6 seconds to understand the slide. 6 lines per slide, 6 words per line, 6 seconds to tackle the slide. Of course, when you give a presentation, just like this talk today or this lecture, you have bad reasons to have a talk and you have good reasons to have a talk. What are the bad reasons to have a talk? To show you that I'm a smart person, or to tell you everything that I know, or to give every technical detail of the work. These 3 troublesome aims make a presentation a hell. So avoid trying to show how smart you are. Let's conclude it. Let's not tell everything that we know, just hints about the main lines of the topic, and let's avoid giving all technical details. What are the good reasons to talk? To give the outline of the whole idea, giving you guidelines through the subject, and trying to stimulate you to read about the article. Using color schemes is very important. You should make it easy to read, and contrasting. And I always suggest dark typing on light background, using colors like yellow on dark blue, or black on dark blue, or gray on red, or gray on green. All this gives distraction and a visual noise. Use animation, no problem, but try to make it minimum and to the purpose. Remember always that data are convincing and images are stimulating. For example, if I say the eye is small, is it more convincing, or when I say the eye's anteroposterior diameter is 23 millimeter? Of course, the data, the figures are more convincing. If I tell you 2 plus 2 equals 4, tell you that the square root of 16 is 4, all this gives you direct data. One of your colleagues, Dr. Asma, left because she probably thinks that this is not important. And once she comes to us and we ask her for a presentation, she will fail to do a good job. Problem, big problem. Now, using animation, data are convincing. And the third thing is images are stimulating. For example, when I tell you eye, it's not like showing you a figure of an eye. Always remember that our left brain hemisphere is designed for mathematics, talking data, facts, giving analysis, while our right brain hemisphere is meant for emotions like the mood, romance, music, and so on. Together, they both give a good communication. So try always to grab attention by a story, by a quotation from someone, by a question that you pause and wait for an answer, or by a joke. So thank you very much. And now you may ask any questions. Yeah, there are only two of you, Dr. Hussam Saq, Dr. Justina Adli Awad. If you have any questions, you can mute yourselves and talk.
Good morning, Doctor.
Yes, good morning.
Do you prefer any textbook for anatomy studying, especially applied anatomy?
There are so many textbooks. بس هو الحقيقة يعني أنا أفضل إن حضرتك